Okay, so here we have the shoulder. So it's made up of the humerus and then also the clavicle on the front and then the scapula onto the back. So we have some different landmarks to go over. So maybe we'll start in this aspect here on the front. So we have your sternum, so your sternoclavicular joint, which attaches from your chest. So my clavicle here attaches from here, sternoclavicular joint. Then we travel across and we get to your acromioclavicular joint, essentially where the ligaments attach to the bone in that aspect. Then if we were to go lateral here, we have your humerus, and then we have your superior, your inferior, and your medial ligaments here of the humerus. If we were to look on this side here as well, we also have your coracoacromial ligament, which are where we have slight bony prominence underneath your collarbone, and then that attaches onto your acromion. We also have this supraspinous fossa, so your supraspinatus muscle attaches to here, and the tendon goes underneath here and comes out on the opposite side of the humerus here. So sometimes what can happen is you can have an impingement of your shoulder. So I'm going to take this and show you on this one instead. So we have the humeral head in this position, and sometimes what can happen is we can have an impingement onto the shoulder here, so that it rotates medially forward from the tension normally coming through the front of the anterior fibers of your pec. Maybe it could also be your serratus anterior, some things like that, that could assist in rotation here. And then also tension through your supraspinatus too could, to a lesser degree, do this as well. But basically, the humeral head butts up into the joint, and then it restricts the gliding movement that's supposed to happen here. So we're supposed to have this upward rotation that starts from in this aspect and comes all the way up to 180 degrees. When that happens, we also have 90 degrees of shoulder blade rotation. So as this rotates up, this also rotates up, and this works 2 times as hard as the shoulder blade does. Okay, so then we also have some basic muscles that attach, where most of my clients, to be honest, I would say come in with quite a lot of shoulder pathology, where it might be that they have adhesive capsulitis, so they have a restriction into the joint capsule itself of the shoulder, which restricts this movement sometimes in that aspect. Or they may have in other aspects being lifting something or having caught something. For instance, somebody might be out walking with their kid and their kid jumps and they go to catch their kid. They then end up rupturing some type of part of their rotator cuff, whether it be their infraspinatus on the back here or their supraspinatus. Could also be on the front where we have subscapularis as well, or on the outside where we have some trigger points, your teres major, teres minor muscles that attach to there as well. So very basic understanding here of the shoulder. So maybe let's have a look as well, and we will talk about, some people will come in and say that they have neck pain. So often what can happen in this case could be that the shoulder blade is not doing the work that it's supposed to be doing, so that there's a dysfunction somewhere where there's maybe muscle that's weak or a muscle group that's weak, which will mean that it will then make the joint above work that a little bit harder. So for instance, if you have pain into your cervical spine, it may be because that's overworking, so your neck may be overworking, and then your shoulder blade itself may be underworking. And then if we can correct your shoulder blade as an approach, for instance, and sometimes what will happen, so if I was to rotate here, some people may protract in this instance here, and then when that happens, the shoulder blade rotates forward, which puts pressure onto the facets of the cervical spine of your neck. So then it restricts the movement and extension, essentially. And then the opposite would be retraction, so where it retracts back in this position here. And then we can see when that's happening, things become lengthened also. But if we rotate it back into a protracted position where maybe the pec major, pec minor is pulling and serratus anterior is pulling, then if it pulls forward in this position, it's going to lengthen the muscles on this outer edge here. So your infraspinatus, teres major, teres minor are being pulled, and then also your rhomboids, which attach on the medial aspect here of your shoulder blade. We also have around here, we've got your inferior angle, we have your superior angle, and then we have your spine of scapula.